if your patient lay down in supine position. In supine position, hepatorenal pouch is the most deeper part at the upper part of the abdomen. And of course, we have more recess. So when I say recess, it means some blind part that it may be some elements trapped on this. For example, at the infracolic space, if I introduce you some recess, it means it may be a small intestine being trapped at this recess. Okay? Now, look here. Here, this is the transverse column by its meso. Please look here. Transverse and meso transverse column. Left colic fracture, right colic fracture, jejunum and ileum. The continuous of this should be ileum. And here you can see the duodenal junction. I mean, this is the duodenum and this one is jejunum. Duodenal junction. And we can separate jejunum from the duodenum. But all of these belong to a small intestine. Just 10 first inches of the small intestine. After stomach, we say duodenum. And the other part, we say jejunum. And the terminal part, we say ileum. Okay? So, when I look here and answer my question. When I collect all the small intestine and push them to the right side, on the left side, in which space? Look here. Left. Infracolic. In left infracolic space, we can see duodenal junction here. At this point, there are some recesses. The most important, I will introduce you. Look here, this one is inferior duodenal recess. And this one is superior duodenal recess. Superior duodenal recess orifice or oval of these recesses look to downward. I mean, a small intestine, if going up, can trapped in this recess. Superior duodenal recess look downward, yes? And the inferior duodenal recess orifice look upward. I mean, from the superior part, the small intestine can reach to this pocket-shaped recess. Yes? Yes? And look here, this one is inferior mesenteric vein. We have two veins and two arteries, important veins and artery. I will introduce you in near future. Superior and inferior mesenteric artery. Superior and inferior mesenteric veins. I mean, I remember that you are familiar with the inferior and superior mesenteric vein, yes? Because when we discuss about the portal vein, I introduce you these two important veins, yes? So, this one is inferior mesenteric vein going up, and at this part behind of the pancreas is trying to join to the splenius vein. Yes? I told you this before. Yes. So, here you can see the inferior mesenteric vein. At the right side, look here, this is the right side. At the right side of the inferior mesenteric vein, it may be find another recess that we say paraduodenal recess. Look here, if something being under my lab coat that protrude the lab coat, at the right of this, it may be we can find a recess like this. If it will be flat, there is no problem, as we have here. But because of this vein, I mean inferior mesenteric vein under the peritoneum, it's caused it being eminence, and at the right side of this, there will be a recess. Para-duodenal recess. Inferior duodenal recess, superior duodenal recess, and para-duodenal recess. If you ask me about the level of these two, inferior and superior inferior and superior duodenal recess, I say superior duodenal recess is at the level of L2, and inferior one is at the level of L3. L2, L3. If you multiply this into 225, it is reached to 50, and this one should be 75% of the appearance of creating of this recess in the body. The percentages of how we can find the superior duodenal recess is 50%, and the percentages for the finding of the inferior duodenal recess is 75%. It means it may be open an abdominal cavity, but couldn't find this recess because of these percentages that I mentioned to you. Yeah. Superior duodenal recess, what is it? Inferior duodenal recess orifice look upward or downward? Upward. And the superior one looks downward. Lateral of these two, we have another recess. Para-duodenal recess. Para-duodenal recess, open to the left or right? Right. The orifice is here, on the right. Is clear? Yes. Okay. So, in this slide, as you can see here, show you the picture that I drew on the blackboard. I mean, this is the mesentery. This one is ascending colon, transverse colon, descending and sigmoid, and this is the mesentery. So here, this one is right, infraocular, and this one is left. Because of this way, left one has access to pelvic. Now, who can tell me paraculic grooves? Look to the paraculic groove. Paraculic on the right side, right paraculic, right paraculic groove. At the, I mean, on the right side is limited by secum and ascending colon. And on the right side, which one limited this groove on the right side? Look here, this is the right paraculic groove, yes? On the left is reach, as she said, to the secum and ascending colon. On the right,
descending colon.
Are you sure? Look.
Oh yeah, you are asking us if the right and we give answer of the right. Now we should go to the left.
Here, this is the right paraculic groove. Yes. On the left, which one?
Ascending.
Still, this groove. You say secum and ascending colon. I say yes, it's true. Now I ask you about the right. Look.
Ascending colon.
Still no.
Abdomen muscle. If I push my hands inside of this cover, you say at the right this, at the left this. Why are you mixing this? So, look carefully now on the left. Left paraculic groove at the left side limited to descending colon and sigmoid. And at the left limited to abdominal wall, abdominal muscle. Okay? It's clear?
Yes.
Which part is this? This one. Sigmoid. This one is, look here, this is the sigmoid. If I pull up the sigmoid, it should be like this. It means this is the horizontal arm of the meso of the sigmoid, and this one is vertical. Horizontal and vertical band. Yes? The sigmoid attached to the posterior wall like this. So, if I pull up between junction of these two arms, we can find a recess. Look here, this is a recess. Intersigmoid recess. What?
Intersigmoid recess.
What is the importance of the intersigmoid recess? Is there any possibility that some small intestine going through this and trapped in this recess?
Yes.
Look here and again answer my question. Is it possible that a small intestine here can go under of these? No, it's impossible. So, what is the advantages of this recess? This recess show you in operating room or dissecting room that you easily can find left ureter. Left ureter. Why? It's difficult to find right, left ureter. I say yes, because when the urine goes through this tube, it's bulging. But when it's empty, it's collapse. Yes? But in dissecting room, we can find easily and point to this. When we find this recess, we can point to the left ureter. Yes?
Yes.
And of course, in surgery room, it can be useful. Now here in this picture, he made a cut through the greater omentum at the region of the liver, at the stomach, as you can see here, and pull up the stomach, show you the bursa omentalis. Bursa omentalis at the below, I mean here, limited to this attachment, meso of the transverse colon and superiorly. Again, reach to the liver and the esophagus. At the left, it reaches to the ligament that attach the stomach to the spleen, gastrosplenic. So this one is gastrosplenic ligament. And posterior than this, the spleen attached to the kidney, left kidney, by lieno-renal ligament. So this one is lieno-renal ligament. In lieno-renal ligament, we have some important elements. Look here, this is the tail of the pancreas. This one is the splenic artery and vein. Splenic vessels, they are important elements. It means you cannot, by catheter or by knife, cutting this ligament, because inside we have pancreas and the vessels of the spleen. And here, between the stomach and the spleen, still we have some arteries. So we cannot make a cut through these and reach to the bursa omentalis. But here, he made a cut through the greater omentum near to the stomach and reach to the bursa omentalis. It means he made the cut through vessels here. It's not a real way to reach to the bursa omentalis in dissecting room or in surgery room. Okay? There is just one orifice or at the right side, as you can see here. Look to this probe. This probe, this rod, I don't know what do you say to this. This finger point-like shape goes through an orifice and can reach to the bursa omentalis. We have a foramen at the right side of the lesser omentum like this, that two of our fingers can go through this orifice and reach to the posterior of the stomach. This foramen is foramen Winslow. So let me to show this to you. Look here. This is the stomach. This one is lesser omentum. Yes? Lesser omentum at the left side of it is attached to the stomach, and at the right side it attached or reached to the liver. At the upper part is limited, I mean firmly attached to the elements that you can see here, stomach and liver. But at the most right side of this, we reach to an orifice that is let us goes through this orifice from the greater sac and reach to the lesser sac. Foramen Winslow. Could you please tell me foramen Winslow anteriorly limited to what?
Anteriorly?
Yes. Lesser omentum, yes. This is the lesser omentum. So this is the free margin of the lesser omentum. It has a name. We say hepatoduodenal ligament. What? Hepatoduodenal ligament is the most right part of the lesser omentum, or the free margin of the lesser omentum. If I open this, it's made by two layers, yes? If I open this, at the back, I mean the most posterior elements that we can reach to that in hepatoduodenal ligament, it should be portal vein. What? Portal vein. So, portal vein from the retroperitoneal space trying to reach to the liver, it chooses this ligament and goes through this ligament to reach to liver. Why it chooses this ligament? Because the first part of the duodenum divided into 2 inches. Yes? The first inch is intraperitoneal and second one is between these two. Imagine my wrist being the part of the duodenum that is retroperitoneal. My finger, if bonds reach to my forearm, goes through this area without piercing the peritoneum. So this space, this junction being intraperitoneal and retroperitoneal, make a space that the portal vein easily reach to the liver, intraperitoneal. Anterior and to the left of this vein, you can find an artery. Anterior and to the right of this, again, you can find a duct. Which duct is this? Bile duct. Come on, bile duct. Which artery it should be? What? Hepatic artery. And what was this?
Portal vein.
Portal vein. So, between the two layers of the free margin of lesser omentum, or between two layers of hepatoduodenal ligament, when we open this, we reach to portal vein, the most posterior one, anterior and left to this hepatic, anterior and to the right one, bile duct. Common bile duct from the liver wants to join to the duodenum. duodenum, second part of the duodenum was retroperitoneum. Liver is so when it wants reach to this part, it choose the hepatoduodenal ligament and easily reach to the second part of the duodenum. It's clear? Again, in 2 minutes, please review.